Good afternoon, everyone. My name is Michaela Hickey. I am pleased to welcome you to What's Up Doc, a monthly lecture program brought to you by the Concord Hospital Trust. Concord Hospital Trust would like to recognize and thank the Walker Lecture Series for their generous sponsorship of What's Up Doc. The Walker Lecture Series offers a wide variety of programs on history, art, and science, as well as dramatic, musical, and literary performances. All events are free to the public and held at the Concord City Auditorium. We encourage you to check out their website at walkerlecture.org to view their calendar of programs. What's Up Doc is proud to welcome Dr. Steffen Haider. Dr. Haider's topic today is Interventional Radiology, leading edge treatments for oncology patients. Dr. Haider joined Concord Hospital's affiliate provider practice, X-Ray Professional Association, in 2021. Following medical school, Dr. Haider completed his residency at Columbia University Medical Center. Dr. Haider is board certified in interventional radiology and diagnostic radiology. Please join me in welcoming Dr. Haider.
Hey, thanks. Thanks. Thank you, everybody. It's nice to see you, and thanks for the opportunity to share a little bit about what we do in interventional radiology. Good. So the idea today is to give you guys a little bit of a sense of what interventional radiology is and how we interact with other medical specialties, and then specifically how we are involved with cancer care in all myriad ways. It's a very broad specialty, and we'll give you just touch on a few different areas, hopefully give you a sense of anatomy, some of the disease processes, and some of the innovative ways that we can treat oncologic disease, cancer, in minimally invasive ways. So first off, what is interventional radiology, IR? So it's a procedural specialty defined by image-guided, minimally invasive techniques. So like, as opposed to most specialties which are defined by a disease process or an organ they work with. A gastroenterologist works with the gastrointestinal tract, GI. Oncologists do cancer care. Cardiologists do heart care, cardiovascular care. We interact with most medical specialties, and we're head to toe. So it's in some ways an old-fashioned thing where if someone's got a problem and there's a minimally invasive way to treat it, oftentimes we become involved. So we'll touch on the different techniques that kind of define the specialty, and then so it's interesting to think about ways to treat disease that maybe not even come up with yet. So again, it's head to toe. We in the hospital here, we treat people everything from the space around the brain all the way down to the tips of the toes and everything in between. So that means there's a tremendous amount of collaboration with all the other specialties in the hospital and everyone who does oncology in the hospital and in the region. We work with them as well. And it's innovative. So everything, simply because it's minimally invasive and image guided, we'll show you what that means in a moment. It means that we're constantly changing and evolving, which makes it really fun and exciting because we can offer treatments that have less risk than traditional approaches, things that used to require large operations, week in the hospital, months of recovery. We can now do it as an outpatient basis. You go home the same day and maybe a little bit of an ache for a couple days and that's it. So less recovery, and hopefully looking for similar or better outcomes. So what are we looking at here? So this is what an interventional radiology suite looks like. This is it's called a fluoroscopy table. So it's so we do a lot of our work in operating rooms. We have our own special operating room that has the tools that we need. And in this case, this is called a fluoroscopy. So in fluoroscopy, we have a large TV monitor, a live X-ray that's on a boom that can go out in huge variety of angles, so we can image any specific part of the body that needs to happen. And then the procedure is done all through pinholes while getting deep into the body. So, and the other reason we do it will be image-guided procedures using CAT scan, so using live CAT scan. And that procedure is done in a CAT scan room. If everyone's had a CAT scan, it's a little donut hole like this, and it creates a 3D picture of the body as a person lays on this table and runs in and out of it. We put little needles and tubes into the body under the CAT scan guidance, so there's no big incision, but we can still get into almost anywhere in the body, again, without a big recovery. And finally, ultrasound. We use a tremendous amount of ultrasound, which is, again, a little handheld device that shows you live pictures of soft tissues in the body, and that can help guide needles and wires and tubes that we use. So again, I'll kind of go through this organized, just like the procedure, the specialty is organized, is by the approach and the types of procedures that we can do, and then we can apply it to diseases all over the body. So that can range from something called embolization. So embolization is the blocking of abnormal blood flow. So, and then arteries and veins go anywhere in the body, and if there's abnormal bleeding from those, we can navigate little wires and tubes through the arteries themselves under image guidance from live X-ray and plug up a bleeding artery, and pretty much anywhere in the body. Or if there's a tumor somewhere, which involves with cancer care, we can guide little wires and tubes out to the tumor and then inject all sorts of manner of particles and devices to clog off the blood supply to the tumor, and then either kill the tumor completely or decrease the size of a tumor to control a problem that it's happening. And that can be benign or malignant tumors and a whole variety of everything in between. Next is a thrombectomy, angioplasty, and stenting. So this is a classic thing where if an artery is blocked, either it's narrowed because of atherosclerotic disease or tumor disease, we can get wires and tubes across it, again from a pinhole access somewhere in the body, and then use the balloons and metal stents to open up that narrowed or obstructed artery or vein and restore blood flow to where it needs to go. Drainage of fluid. So fluid can become trapped anywhere in the body, sometimes from abscess or infection. Sometimes folks have gallbladder disease or biliary disease, or a disease in the drainage of the liver or the kidney. And if that fluid can't get out because of maybe cancer is blocking it, we can place tubes into the body to drain the fluid out. Again, no big incision, just a tiny little tube, and thereby solve a problem. Vascular access. So there's all sorts of reasons folks will need to have access to the veins in the body for chemotherapy or so. So we provide large volume of metaports or special devices that allow medications to be given. Very common thing we do is called a biopsy. That's involved in cancer care. So biopsy is just taking a sample of a tissue that you don't know what it is based on prior imaging or clinical concern. We take a small sample of it in a minimally invasive way so that pathologists and the rest of the team can get a sense of what it is, whether it's cancer or not cancer, or if it is cancer, how to treat it. Ablation. So this is the destroying of abnormal tissue. So in ablation, historically, a cancer that was localized would be treated with a surgery. Big open incision, and take out the cancer, and then close the incision, and then long recovery. Some types of cancers, specifically in the kidney and in the liver, sometimes are amenable to something called ablation, which is where we insert a probe under image guidance right into the body through a tiny little skin nick. There's no surgical trauma, and that probe on the end of it will have a heating or cooling element, and so we either burn or freeze the tumor. And so there's no big incision at all. It's just freeze or burn a tumor to destroy it. And finally, sometimes we use cement to fix spine fractures as well. We won't get into that today, but it's just another approach. So broadly with interventional radiology and cancer care, we're involved from the beginning to the end of a cancer care, and that's a really nice thing to be able to help out with. So everything from diagnosis. Most cancer care starts with a diagnosis, and usually that requires a tissue sample. If it's a tissue sample somewhere deep in the body, or even areas that are close to the skin, we'll oftentimes do a biopsy through interventional radiology. So there's a good chance that if someone is diagnosed with cancer, at some point they'll interact with us for the diagnosis. And I'll show you a little bit of how we do that procedure. And then treatment-wise, folks who get chemotherapy or immunotherapy through a Metaport, which I'll show you pictures of that, oftentimes they'll come to us. We do a really nice job with them. It's a quick 20-minute procedure in and out, you're with the hospital for a couple hours and then on your way. And then control of disease. So this is, in some cancers, we can control disease very well locally. So that's in liver cancer or kidney cancer. We'll show you examples of this, how we can destroy tumors without even spending a night in the hospital. And then palliation of symptoms. Oftentimes you think of cancer care as just treatment, but a lot of it is sometimes we can't fully cure cancer. So a lot of it is going to be controlling symptoms and improving quality of life. So we're very heavily involved with palliation of symptoms. Everything from opening blocked arteries, opening blocked fluid pathways in the body, draining fluid in the body that it becomes painful either in the belly or in the chest. We drain fluid out very frequently for that. And we'll show you examples. So first off, let's start with an example of a biopsy and ablation. So In this case, and this is work that's done in a CT scan room. So again, just like this, where the interventional radiologist and our team, we're working with the patient right on a CT table, and then we'll insert wires and probes and needles right from the skin into the body under the guidance of this CAT scan in live time. So again, there's no incisions, a tiny skin nick, just enough to get a few millimeter diameter probe in. So this is a case of a 37-year-old gentleman, otherwise well. And on imaging, he was incidentally found to have a nodule on his kidney. So what we're looking at here is an MRI. And we'll go through imaging as well, because it's kind of fun to give you a sense of these things. And this is a picture of a kidney outside the body with a tumor on the top of it, right? So the kidney is basically the kidney bean shape, and it has the normal tissue of the kidney is this stuff around here, this pink stuff. It takes blood flow in, it filters the blood, and then releases urine out to get rid of toxins and fluid from the body. And that fluid flows down through the renal collecting system into the renal pelvis and the ureter. So this is where the urine collects and goes down towards the bladder. So in this case, we're looking at the front of the kidney, front of the body straight on. This is the liver. This is the spleen. Right here in the middle is the spine. And on the left, everything's backwards with imaging. But so this is the left side. This is the left kidney. Normal left kidney. This is this sort of oval shape here. The center part is where that urine collects, or the area of it. On the right kidney, we can see normal tissue, and then here something's abnormal, right? There's some kind of a nodule here. So we don't really know what it is, but and this is an example of injecting X-ray dye or MRI dye into the body, and then watching where the MRI dye goes. So this is a case where things that have enhancement or blood flow to them become bright. So the kidneys have a tremendous amount of blood flow; they become bright. A tumor also has blood flow. In this case, it has blood flow, so it's worrisome for a tumor. And then actually on a follow-up, the initial imaging was done maybe a year prior to this. I don't have the picture up here, but it was smaller and then it had grown. So that's very concerning. So a growing mass in the kidney that has blood flow to it, well, that's kidney cancer until proven otherwise. So how do you treat it? In the old days, you take an open operation or some kind of an operation and you have cut part of the kidney out and then take that tumor out, which is a great option. But it involves quite a bit of recovery, and it's painful. It requires days in the hospital, and then again weeks to months of recovery. So instead, we can do something called a cryoablation procedure. Cryoablation is a really nice modality for treating mostly tumors in the kidney, and what it involves is this thing right here. So this is a zoomed-in view. This is a cryoablation probe. It's a metal poker, maybe a few millimeter in diameter, and on the tip of it, there's argon gas is pushed through the inside of this probe, and then the tip of the probe up here, there's an expansion chamber, and the hyperdense or hyperpressurized argon gas expands and sucks in energy and creates an ice ball around it. So what you see here is this ice ball that forms around the probe, and it's been studied in models to get a sense of how big the ice ball is and where the kill zone would be. And everything inside of the -20 to -40 Celsius line that is completely destroyed. So this is an example here where we do that. So what you see is the patient's lying on their belly. This is the spine. This is the back. And this is a grid we place on the outside to help us decide where exactly to place the probe. This is the kidney. And this is actually the colon, so the intestines. And then here's this tumor, which had again grown a little bit. So what we did is place this probe. So this is a picture of the metal probe coming into the body from the skin all the way down. And on CT scans, anything metal is very bright. And it goes right, we managed to place this probe right through the tumor. So you can see this little bump here is that tumor that we saw earlier. Place that probe right through the bump. But then this tumor is pretty close to the colon. And again, we don't really want to break the colon. The colon is important. That carries stool. And if you freeze the colon, you create a hole in it, and then a person has a bowel perforation. That's an emergency. So we don't want to freeze that. So then we have to push that away. But again, everything's minimally invasive. We don't want to open the patient up. We want to do everything with as little trauma as possible. So in this case, what we do is place a separate little needle in, and then inject fluid in to basically push the colon away, and to create a nice safe margin. And then another needle will go in and take a biopsy sample to confirm what this is, which was cancer, renal cancer, in this case renal clear cell carcinoma. And then we turn on the argon gas flowing just within the probe. And again, we can see here, see this kind of this dark kind of oval around the probe? Can you appreciate that? So that's the ice ball forming within the patient, right around that tumor. And everything within this ice ball is now destroyed. So you can see the colon is nicely away from this, not destroyed, but the tumor itself is completely frozen and within the margins of the procedure. That's it. And then, so we do that for about 20 minutes of freezing, and then it's unfrozen, the probe comes out, needles come out, and the patient wakes up from anesthesia, and they go home a couple hours later. Yeah. So the outcome, right? So this is before the procedure. We saw this. Here's that tumor. And then a year later, follow-up imaging, there's a little slice of the kidney taken out, but no tumor. It's gone. Again, no residual tumor after ablation. And again, this is all working with our urology colleagues. So the urologists, the surgeons and medical doctors who take care of the genitourinary urinary tract, and from kidneys to bladder and prostate in men. They send these patients to us, we treat them, and then we manage them in the long term afterwards. So it's a lot of collaboration. We'll just call up our urology friends on the phone, or they call us, and we constantly talk about cases. And particularly for small tumors like this is a great option because, again, you go home the same afternoon the procedure is done. So renal tumor ablation, getting a little bit of the literature of it, right? Everything's done, but there's a grading for all tumors. For tumors less than 4 centimeters in size, there's really outstanding efficacy with this cryoablation approach, or ablation in general. It's called a T1A tumor. Primary efficacy is about 96 to 98%. So 96 to 98% of the time, completely able to control the tumor. And control mean destroy, gone, like it never existed before. For larger tumors, I showed you a small tumor, 2 centimeter one, but sometimes tumors are larger, right? So if they get to the range of 4 to 7 centimeters, sometimes we can treat it. It's more complicated. We have to use more of those ablation probes, and there's greater risk of both complication and incomplete treatment. But for some folks who maybe have heart disease or some other comorbidity that would say, well, maybe they won't tolerate a resection of large tumor, this becomes a very nice option. And again, even at recurrence-free survival is still 97, 86, 63% at a few years out. And so it's, again, similar, slightly not quite as good as operation at the larger size, but for some patients, that's better than the risk of an operation. Okay. And again, it all has to do with collaboration now, just working with our colleagues to figure out the best treatment path. Any questions about this one? Yeah, cool. So we'll do another example of ablation. And this is more again, a collaborative, a complex case with ultimately a great outcome. So this is cancer. What we talked before was primary cancer that was started in the kidney and will never leave the kidney. Right? That's the grand hope of cancer care, is to find a cancer early. In that case, it was not symptomatic, but 5-10 years from now, that patient would have had very major problems, including possibly life-limiting issues. But sometimes cancer, oftentimes, is not found early enough, and it's already gone. It's spread throughout the body. So then, again, we're in palliation and control, so improving quality of life and in control of disease, without necessarily being able to ultimately completely remove cancer from the body. But that's okay, and I'll show you why. So in this case, there's an 80-year-old gentleman. He has a history of metastatic colorectal cancer. So 3 years prior to him interacting with us, he had metastases to the liver. So here's a picture of the liver. The liver is in the upper right quadrant of the abdomen. Large organ, very important for metabolism, energy production and storage, one of the most important organs in the body. And in this case, you can see that this patient here has tumors, so these white bumps on multiple areas of the liver. Classically, the procedure would have been to go in and do a really large operation called a hepatectomy or partial hepatectomy and remove tumors, remove parts of the liver. And this patient did have that, and he had it 3 years ago, and he had a really bad course with it. He was in the hospital for a couple months afterwards, had infections, complications. Again, but it controlled the tumor. It was great. It did it. But again, it's a major operation, and things can go wrong. But now he's off chemotherapy, and he did well. But once cancer has left the colon, for instance, right, it's in the body and it can pop up again anywhere in the body years later. In this case, it did. And we're looking at CAT scans. So what we're seeing here is that there are, in every 3 to 6 months, patients who have metastatic cancer will have some kind of imaging done of their body to look for new sites of cancer. Because the earlier you can catch a recurrent disease, the earlier you can treat it. So in this case, we see here a couple spots and dots. So if you can look really closely, right, this is looking at the body sliced up like a loaf of bread. So we see the front, back, this is the aorta, this is the spine we're seeing right here, left side of the body, right side of the body. So this is the liver, the black areas here are the lungs, and this right here is the stomach we're just seeing a little bit of. So we can see right here is a little tiny dark spot? That was new, and that's the site of a new site of cancer. And down here, again, we have another. You see this area right here. This is the back part of the kidney, the posterior right lobe. You can see again, it's a little bit darker than the rest of the kidney. That's another site of new cancer. So in the meantime, he started some therapy again and some chemo and started figuring out what we can do about this. In the meantime, he got a new updated CAT scan. Well, at the time of the procedure. We got these images and we said, we know this needs to be treated and we can probably do this in a minimally invasive way. He wasn't interested in going through an operation again. So same approaches we used in the last case, we can use for this case too. If there's a tumor somewhere and it's small enough, we can put a probe in and freeze it to death. Or in this case, it's burn it actually. I'll show you that. But from the time that CAT scan was done to the time he actually got onto the procedure was about 2 months later. The lesion had grown from 11 millimeters to 16 millimeters. Right, so that's quite a bit of growth. And similarly, the lesion at the back of the right liver had grown a lot from 3.6 centimeters up to 6.8 centimeters. Rapid, really scary growth of a tumor, right? That's up to now, so this is not amenable to our kind of treatment. Once a tumor gets this large, you need to do something else. Because we can't safely burn enough of the tissue without burning too much normal tissue around it. So this is complex disease. We have a small tumor, which could nicely be treated with one session. We have a large tumor that could be treated with an operative resection, but he doesn't want that, and there's other ways to treat it. So this comes into collaboration again. So how do we do things, right? We talked a lot about operation, right? It's taking out sections of the liver, but that's a big deal. Microwave ablation. So this is, in the liver, oftentimes we'll, instead of freezing a tumor to destroy it, we'll use a probe and then burn it. And the burning of the tumor is helpful because it cauterizes or stops the blood flow from around the margins so it doesn't bleed. And the liver has a tendency to bleed after these kinds of procedures. With microwave ablation, it doesn't. And then with our colleagues in radiation oncology, there's a really tremendous procedure which is stereotactic body radiation therapy. And that involves high-intensity radiation given through radiation beam in multiple angles around the body to pinpoint a high dose of radiation at one site without delivering too much at any one pathway to get there. And this is we work often with our radiation oncology colleagues to figure out what the best choice of treatment is. So in this case, that large tumor at the back of the right kidney, you could probably do radiation for that to try to decrease the size of it. This one right here, you could do radiation for it too, but the radiation treatment itself usually takes about 2 weeks of going every day for radiation sessions. There's just a lot involved with it. So it's it can be intrusive into life, but it's also non-invasive. And there's different reasons to do each type. So what we decided upon was to treat the smaller tumor that was still small to be treated with the ablation, the microablation, with the ablation therapy, with us putting a probe right in, just like the kidney, probe from the skin right through the liver at an angle to avoid important structures like the lungs, the heart, or central structures in the liver like the major blood vessels, right into the tumor. And again, this is all under image guidance, and we have to do a lot of manipulating geometry to make sure we get just the right point. And then we turn on the microwave probe, and it creates, you don't see it on the imaging, but it creates a burn zone, an oval around this tip that destroys anything inside the tumor, inside that region. And you can see that here on an MRI that was done a couple weeks later. You see this is where that tumor, right, initial picture right here, this is that tumor up here at the top of the left lobe of the liver. A few weeks later, you see this oval right here. That's the ablation zone. So everything inside that ablation zone is destroyed, and that included that tumor. It's completely destroyed. Now for the right hepatic lobe tumor, you see on this CAT scan here, you really can't see that right lobe tumor that well. So what we do for our radiation oncology colleagues to be able to do their radiation therapy is we put needles into the body to place a bunch of little gold markers right here all around the tumor, so that when they do the radiation therapy, which itself is guided by a CAT scan in real time, they basically can lock onto those little gold markers we placed, and then as the patient is breathing and the liver is moving up and down, the radiation beam can follow those gold markers to focus the beam right on the tumor. And so we had to figure out, we did all these fancy things, then we figured out if it helped, if it did anything useful. So, and this is typically followed by some biochemical markers, looking at that might produce, something called CEA, which is an antigen that is produced by tumors, and it can be a marker of tumor recurrence. But importantly is with imaging. So again, now we're looking again at an MRI. And this is the lesion in the left hepatic lobe that we treated with the microwave ablation. And again, on this is a picture of contrast enhancement. This first one was focused on here to start. Everything bright has blood flow in it. So this is the aorta, the main artery in the abdomen and chest. This is that tumor. So this is before the treatment. See, there's a little rind of bright material. That's the rind of the tumor, the metabolically active part of that tumor. And the center is sort of the necrotic portion where there's just dead tissue, but the tumor is growing and expanding like radially out from here along this bright margin. That's before. Afterwards, it's just gone. There's a little ablation zone of you don't see any enhancement, and it's just this little dark swash, and that's destroyed tissue, including the tumor. Similarly, this is called diffusion-weighted imaging, and it doesn't really matter the names of it, but it's an interesting modality because it looks at the free flow of water. So something where tumors are very dense with cells, and a cell traps water inside of it. So a tumor will typically have restricted diffusion of water, restricted motion of water. And this is anything that has restricted motion of water due to high clumped cells together will be bright. So this is that diffusion-weighted imaging. Before the treatment, this is the bright little blob here of the tumor. Afterwards, the same spot, nothing, it's just gone. So tumor's gone, that's it, destroyed. This is the interesting one though. So this was previously a 7-centimeter tumor. And then after we placed those gold markers to help the radiation oncologist, and then after 2 weeks of radiation therapy of high doses, that tumor had decreased down to, what does it say here, 3.8 centimeters. So about 7 to 3.8 centimeters. Tremendous. This is a tumor that had grown, remember, almost doubled in size over 2 months, and now it just sucked right down. But it's not destroyed yet, right? It's not dead, as opposed to this treatment over here, where there was no enhancement anymore, no blood flow to it. This tumor, and you can see right here, this sharp line, this is the line where this is normal liver, and then the radiation zone is right here. And so you can see that there's still a live tumor here, it's just smaller. And over the course of a couple MRIs afterwards, we noticed that some of that enhancement, some of that blood flow inside the residual tumor had slightly increased again. And so at that point, you can either watch it, or while the tumor is still small enough, we could go back and actually do an ablation of that residual tumor to try to destroy the rest of it. So that's what we did. We brought the patient back for the residual tumor in the right lobe, again, which is much smaller now, and we place those probes through it, and then turn the microwave on and try to destroy the rest of the tumor. And so that's sort of a lot of the collaborative work. And this is all email chains and in talking with our oncology colleagues at New Hampshire Oncology Hematology and the radiation oncology folks. It's a very good group to work with. So then we look, what are the outcomes, right? What's the literature say about treating metastatic disease to the liver? And particularly we'll look at, this is mostly focused on colorectal cancer, which is probably one of the more common metastatic diseases to the liver, just because colon cancer is so common. So traditionally, right, the gold standard for large tumors with a good operative risk profile is to do a resection. That may be changing over the years, and sometimes it won't. There's some cases where just doing an operation to remove the part of the liver, to remove tumor is just better. But many cases, there's small tumors, and particularly tumors are less than 3 centimeters in size. And there's only a few of them. This ablation therapy can be very nice because it's one session, you go home the same afternoon, and tumors are treated. Now, between the operative resection and microwave ablation for small tumors, the outcomes are the same. There's really no difference in survival, but there are fewer complications with the microwave ablation, as you can imagine. For the stereotactic body radiation therapy, this is better for large tumors. So tumors that are larger than 3 to 4 centimeters in size can be better treated with stereotactic body radiation. So that's, again, whatever tumor there is, we treat it together and figure out what the best pathway is. Any questions on that? Okay, cool. So now we'll look a little bit about at embolization, or the blocking of abnormal blood flow. And these procedures are done in the fluoroscopy suite. So again, this is the patient lies on this operating room table, and there's TV screens, like playing a video game almost. This is the live X-ray, which we get on these big booms that we move in all different positions to get to just the right view of an artery or a vein that we need to see in order to manipulate little tools into that point. So this is basically putting little wires and tubes along the highway of blood vessels. Most of the access we do is we put little wires and tubes, tiny, the size of the tip of a pen, into a femoral artery, so the artery right here in the groin, or an artery in the wrist. And then from there we can thread these wires and tubes anywhere in the body, up to the top of the head, again into the brain, or the space around the brain, all the way down to the ankles, the feet, and the arms, and all over the body. And the way we do this, right, you can imagine, basically it's like plumbing, right? So you take a catheter or a tube that has different shapes on the end of it to make certain turns, and then a wire within that catheter that has shapes on the end of it, or you create different shapes of it to try to select. So if you're actually accessing an artery here in the groin, we want to get up into the stomach area. We thread the wire up here, up the aorta, and then make a little bend on it to get it into the artery we need to. And then basically knowing what arteries supply what organs, we can find where tumors are or where bleeding is. So in this case, this is a mistake here, but this is embolization, so gastric tumor hemorrhage. So in this case, we have a 78-year-old gentleman. He has newly diagnosed stomach cancer. He presented he was weak for a few months beforehand, wasn't sure why. And they did blood tests and found that his blood counts were very low. And on imaging, it was found that he had what looked like a large tumor. So this is, again, slicing the body up like a loaf of bread, right side, left side. So this is the spleen, this is the liver, front of the body, back of the body. And this right here is the stomach. The bright material is in an oral contrast, so they drank an X-ray dye to be able to see the inside of the stomach. Now the normal wall of the stomach should be pretty symmetric and smooth, but then if you look here, something gets abnormal, right? This is really thick. And that turned out to be tumor. And same thing here. This is the stomach looking straight at the body. Liver, this is the lungs, this is the heart. So the stomach sitting here. The normal stomach wall along the side here, and then this is the abnormal tumor. And our gastroenterology colleagues, typically the treatment starts with taking a look with an endoscope. So a tube goes down the mouth, and then taking a look inside the stomach, and then if they saw bleeding, they saw active bleeding. This tumor had grown so fast and so irregularly that the tumor was bleeding into the stomach, and that's why he had required something like 10 transfusions in the past few weeks. So a tremendous amount of blood loss, and this was in the end of his life. Now, classically, what you'd like to do then is just to take the tumor out. That is always what you should be doing. So you got tumor to operation to remove part of the stomach or all the stomach, and then connect everything back up, and the tumor is out. Unfortunately, he had metastatic disease. So, meaning the tumor had already spread into the lymph nodes throughout his abdomen, and that it's no longer the right thing to do. Probably to do a major operation because the cat's out of the bag. You can't do local control. If you have to, you do it to control the symptoms. But if you don't have to do it, if you control that bleeding in some other way, then that's probably preferable. So then we're thinking about approaches. So if there's bleeding in the body, just call interventional radiology, and we'll figure out a way to stop the bleeding if we can. So in this case, we know this is based on the intricate, detailed anatomy of this upper abdomen. We know what arteries supply which parts of the stomach. So in this case, this is looking at something called the celiac trunk. And that's the celiac axis, the celiac trunk, which is an artery that comes off the aorta. Branches of it will supply most of the stomach. So there's something called the left gastric artery, which supplies the inner curvature of the stomach. And then there are gastroepiploic arteries, so arteries that supply the outside of the greater curvature, the outside of the stomach. In this case, this is the greater curvature, this is the inner curvature of the stomach. So left gastric artery, we know, again, is this artery right here, supplying the inside. Well, maybe that left gastric artery supplying this tumor? Probably is, and if this tumor is bleeding that much, there's maybe a good chance that it has a lot of blood supply that we could treat. So that's what we did. And this is a procedure done on that fluoroscopy table. Patient's not even asleep, give a little sedating medication, but it's not painful. The worst part of it is really just a little needles and tubes going into the groin. We give lidocaine for that, but that's that. You don't really feel much. It's mostly just discomfort from laying on a flat table for an hour or two. So this is a picture, right? So what we can see here is looking straight at the patient. This is live X-ray. This is a little catheter, so this is going into the celiac axis, which is that shaped catheter, just to hook onto that celiac artery right here. And then take something called a microcatheter, or even smaller catheter, goes through the larger one, and then thread out into these tiny little arteries out here towards the tumor. It doesn't show up all that well, but what you can see here is this is the left gastric artery coming up. And then the stomach, we know it just is sitting like you don't see it in the X-ray, but you know the stomach is sitting right here. And normally the left gastric artery should go into little wisps of small branches to the stomach tissue. But in this case, there's a tumor here. So what we see are left gastric artery going widely into these kind of almost out like a tree. You see there's almost like a tree here of blood vessels. And they're really erratic. They go in loop-de-loops. And then it's hard to see here, but on the delayed phase, you see, I can get a sense here, but you see there's like a circle of dark material right here? Can you get a sense of that? That's the tumor. So that tumor just hangs on to that X-ray dye we inject, and that's just a big bag of tumor full of blood. And the blood perfuses through it. But now at least we know where the tumor is. So now the question is, what do you do about this? So ideally, you want to cut off enough blood supply to the tumor to destroy it, but not so much blood supply to the area that you cause the wall of the stomach to die and the stomach to perforate. And then that would be emergency, probably end of life again. Now, the safest thing might be, well, what if you just put a metal coil into here, like to plug up the artery? Well, that'd be great, but then again, we see here, right? There's many arteries that go to the stomach, and little tiny branches would reconstitute and supply the tumor again. Wouldn't do much in the way of treating that tumor. If you put a really tiny, well, maybe we can inject little particles in little teeny tiny beads to go way out into the tumor and block up the tumor itself. Oh, that would be great, but if you make them too small, then they go out into the arteries that can supply the normal stomach, and then you maybe cause the stomach to perforate, open up, and then again you could kill this nice gentleman because you've cut off blood supply and caused the perforation of the stomach. So we use calibrated particles, and we know from a lot of research of what size particle can be used in what part of the body. So in this case, there's been some literature, and again, tumor embolization of the stomach is not well studied. There's small case reports and series on it, but it's not a major primary treatment. So when you have to, but we know that people do inject particles that are 500 microns in size, so 0.5 millimeter in diameter, into arteries around the stomach and the upper abdomen for a variety of treatments. And so that's what we did here. We put this little microcatheter right here and then injected particles in very carefully until just put enough of these particles in very slowly until the tumor itself is no longer filling and these arteries are kind of plugged up right here. And that's basically treating the tumor with tiny particles to cut off the blood supply to hopefully kill or decrease the blood supply enough that the tumor shrinks, but not so much to damage the stomach wall. And that's the example of it here, right? So this is a microcatheter out to a tumor, injecting tiny little particles into a tumor itself to devascularize it. So then what, right? The bleeding stopped, right? So after this, he required no further transfusions. He had a little bit of discomfort the first night. After that, no pain, and he went home a few days later. But then, that's just the start, right? So we've treated a tumor, but he still has metastatic disease, and the tumor is going to regrow if you don't do anything about it. This is, again, the collaboration. So with New Hampshire Oncology Hematology, our colleagues who run the Cancer Center, they did a tremendous amount of testing on the biopsy samples that have been obtained by our GI colleagues with the endoscopy to figure out how to treat this. Now, historically, survival rates of metastatic gastric cancer are somewhere in the 8 to 15% 5 years, right? It's dismal. But the literature is all being rewritten right now because there's this whole new world of immunotherapy. That was all based on old chemotherapy alone. Chemotherapy just tries to halt cell growth or division in some way, but that's non-targeted. It affects the whole body. Immunotherapy is this incredible new developed, and most of these immunotherapy drugs have come on the market in the last 10 years. So I was in medical school and graduated in 2013. We didn't learn about immunotherapy really. And this is all, so everything is new, right? This is constantly changing. But one thing folks can test for is something called PD-L1 expression, programmed death ligand 1. So what this is an interaction between the tumor cell and the immune system, or a T cell, which is tasked with identifying foreign structures, including tumor that shouldn't be there, and attacking it or labeling it so it can be digested by the immune system. Now, these tumors, they can express something called PD-L1, which effectively neutralizes the effect of the T cell and makes it invisible to the immune system, so the immune system can no longer identify the tumor and it can't attack it. Now, what these PD-L1 inhibitors will do is block that effect of that PD-L1, PD-1, and then allow the immune system to identify the tumor to destroy it. And so thankfully, this gentleman did, the tumor was tested for that PD-1, programmed death ligand 1. He had it, so he can get immunotherapy, as well as chemotherapy. Now, what he got was a combination of something called FOLFOX and the pembrolizumab, which is that immunotherapy. The FOLFOX, this is a combination of the traditional chemotherapies, and it's a burden. So on day one, you get an IV placed. You have an infusion for 2 hours, and then the next day, there's a 48-hour infusion of fluorouracil. And so typically what we'll do for folks like this, we'll get something called a Metaport. So they don't have to have IVs placed every couple weeks and basically really just scar and destroy the veins in the arms. And so what this works is we place an implantable device. This is done in interventional radiology as well. An implantable device in the skin of the upper chest with a tiny little tube that goes into a vein that threads down towards the heart. And then basically when these need to be accessed, we put a little bit of lidocaine jelly on the skin, and then the little needle goes right into that port, and thereby sparing all the veins in the body. So he got this, and this pembrolizumab, right? It's not tremendous, but 28% survival versus 18% survival at 24 months. But right, so what's our outcome in this case? Well, just with the embolization alone, really interesting, right? This tumor previously measured about 6.5 centimeters. Well, 2.5 months later, it measured down to just 2.5 centimeters. So just cutting off the blood supply alone to this tumor significantly decreased the size of the tumor, and that was just embolization alone, which is not even part of cancer algorithms for this treatment. Now, this is after embolization, and then the FOLFOX and the pembrolizumab, so the chemotherapy, the immunotherapies. Before, again, the tumor was the CEA. This is that marker of cancer, of this gastric cancer in the body. The number was 358, down to 12 6 months later, so tremendous decrease. And similarly, if you look at the metastatic disease, this is again looking at the body face on. This, if you look right here, this is big glob of metastatic lymph nodes. That's tumor that has left the stomach and has infiltrated the lymph nodes. Well, that decreased just this little thin rind now. Similarly, the tumor before, large infiltrative mass, down, you can barely even see it anymore. So, and this is 7 months out, and he's to this date he's doing great. And this is about about almost coming into a year now later. So, again, all this literature is being rewritten right now, and we can't say what's going to happen to him. But this is control, and controlled as others would have passed away a year ago, and he's still here and doing really well. Any questions on that? And so similarly, right, the idea of cutting off blood supply to a tumor by putting little particles in, that's used in the liver as well. It's used all over the body. Yeah?
You mentioned particles. What are the particles made of?
Yeah, it's an acrylic. It's like a little gelatin acrylic bead. Yeah, they're all proprietary for the companies that make it, but it's basically it's little plastic beads, teeny little plastic, very finely calibrated plastic beads. Yeah. Okay. And now we'll look at something else, which is called angioplasty and stenting. So this is the idea of going into a blood vessel and opening it up that was closed down for whatever reason. So in this case, we have a 74-year-old woman. She had a new right lung cancer. She'd smoked, and which obviously was the culprit reason why she probably developed the cancer. And it was unfortunate for her that the tumor had grown large and fast. So what she sort of presented with was facial swelling, believe it or not. Her horrible headaches and difficulty with vision, swelling in the upper extremities. So how the heck, why would you get that from a lung cancer? Well, let's see. So what we're looking at here is the lungs sit right here, and something called the superior vena cava, which is the main vein that drains blood from the head and the upper extremities.
Sorry.
Oh, that's okay. Comes right next to the upper right chest. So you can see here, these are veins coming down from the head, the jugular veins, and the veins coming from the upper extremities, the brachiocephalic veins, meeting to create the superior vena cava. That's normally supposed to be a brisk flowing tube right into the heart. In this case, unfortunately, this is looking at our patient. Black front, back, left side, right side. This is the upper right chest. This large tumor, see this large mass right here? That's that tumor. So really, I mean, a horrible disease to have. But the tumor where you should have superior vena cava, you don't really have superior vena cava anymore. It's been almost completely compressed by the tumor itself. So what you can see here is that here's contrast being injected, and then through the upper arm, and it's coming here, right here, where it should be going to the brachiocephalic vein. The superior vena cava should be right here, and this is the right atrium, so where the blood comes into the heart. Well, it can't get there because there's a huge tumor in the way. So what do you do, right? In this case, radiation therapy is the mainstay, and chemotherapy, immunotherapy, but that can take some time, quite a while, to have an effect. And I mean, her head felt like it was exploding, because you can imagine all the blood comes into the head and the upper extremities through the arteries, but now it can't really get back. Blood will try to find a way through collaterals to get to back to the heart, but it takes time to develop this, and for her it wasn't going to be quick enough. So what do we do, right? The idea is, if you can get a wire, basically access to a vein in the body, if you can get a wire across that narrowing, then in theory you could put a balloon over that wire and open it up, and maybe put a metal cage in to open that up as well. So this is what we did. So this is superior vena cava syndrome. That's the syndrome of headaches, vision changes, swelling in the face and in the upper extremities. Again, oftentimes due to a tumor in the upper chest. In this case, the access was into the femoral vein down in the groin, and then threading a wire up through the veins of the pelvis, through the inferior vena cava, across the heart, into the superior vena cava, all the way up into the base of the neck. And now, once you've established that wire access, well, then you can put a big balloon in, a big balloon that will open up that space. But then, just by inflating a balloon, well, the tumor's not going to go anywhere. It's going to collapse it right down again. So the idea is to place a metal cage, or something called a stent. This is usually a tube with nitinol or nickel titanium alloy lattice that props open. It's a delivered constrained, and then we remove the sheath that it's constrained in, it pops open. And that's what we have here. So after this stent was placed, from down towards the heart, all the way up above the tumor, you can see there's brisk blood flow right across that channel where previously it was obstructed. So here is before, barely a flow channel, but not enough, really engorged veins. See, this is the base of the neck, that's a jugular vein. Afterwards, you inject the X-ray dye, the vein is no longer engorged, and blood's flowing back to the heart. So our patient, right, she had a complete resolution of symptoms within days. The facial swelling went away, upper extremity swelling went away. She actually didn't have much pain. Sometimes folks do have pain in the chest, can have a headache afterwards as well. Then she went on to get her cancer treatment, right? At this point, it's radiotherapy, just like we saw, immunotherapy, chemotherapy. But the superior vena cava did remain open, and she had good flow. So that was, again, that's palliation. There's no treatment of the tumor itself, but it's just controlling symptoms so that she can get back to her life and actually undergo cancer therapy. So for this, these SVC stents, success rates are somewhere in the 90s, and patency is above 90% for the first year. And a lot of that is going to depend also, on control of the tumor, but hopefully this props that area open enough that allowing the rest of the treatment to decrease the size of the tumor with time. All right, any questions on that one? Cool. So I figure we maybe do one last case. And this is really a near and dear area for interventional radiologists, which is the liver and the hepatobiliary system and the portal venous system. This is a really fascinating part of the body, and we do a lot of work in this area. So what we're looking at here is basically the venous drainage of the gastrointestinal tract, and most of the viscera of the abdomen. So again, the liver is one of the centers of metabolism. So when you eat food that you're eating now, right, the intestines will absorb that food, and then the first stop is the liver to be metabolized into carbohydrates and proteins and fats. So that involves a separate blood supply, separate from the rest of the body. There's the venous drainage of the intestines and the gastrointestinal tract and the spleen and the pancreas. It all goes into these mesenteric veins, into this one called the portal vein. So there's the superior mesenteric vein and the splenic vein drains the spleen and the stomach. The superior mesenteric vein drains most of the intestines. And they meet here to form the portal vein, and that goes into the liver. Now, cancer of the pancreas, so the pancreas basically lives right here, centered on right here in the nook between the splenic vein and the superior mesenteric vein. Cancer of the pancreas oftentimes will obstruct or obscure these mesenteric veins. Thankfully, it usually goes slow enough that their bypass pathways form and blood eventually does get back to the liver, even if one of these main veins is blocked. Kind of like if there's an accident on the highway, traffic stops, but everyone gets off of the exits before, takes the back roads, and gets back on above. So that's the idea. Now this patient had a Whipple procedure. So that's the classic treatment to take care of a pancreatic cancer. To resect the head of the pancreas where the tumor is, attach the remainder of the pancreas to the gastrointestinal tract, and a couple other reroutings that we don't have to get into right now. It's a tremendous operation, but it works, and survival is maybe 25%. It's 5 years later, because pancreatic cancer is a really terrible disease that does tend to metastasize, go elsewhere before it can be treated. And then the patient also got radiation therapy to the bed. So we saw radiation therapy before. Radiation therapy also has some side effects sometimes, and in this case, it causes fibrosis or scarring within the radiation field. But for this patient, they needed it to get control of the cancer. However, a few months, maybe a half a year later, she had progressive abdominal pain, worsened with eating, and then developed fluid building up in the abdomen, and as well as weight loss. Not expected. So if we look at right after her Whipple procedure, this is, again, looking at the liver, and this is the portal system. And then right here, this is that splenic vein, and the superior mesenteric vein will be right here. But it looked nice, and some of the stuff is out of plane, but intention here is these veins are wide open, and allowing blood to nicely go from the intestines and the spleen and the liver and the stomach and the remainder of the pancreas right into the liver for normal blood supply, normal metabolism. However, as there was progressive scarring, you can see that, well, it's kind of hard to see, but there's a little bit of a subtle grayness, haziness around this splenic vein, around this portal vein down here. And this is 7 months later, and then 9 months later, it really progressed. See how there's just a thin little wisp of this vein? Now that vein that's supposed to bring blood back to the liver has been constricted down by scarring or tumor. There could be tumor in there too. And now you can imagine that if the intestines can't get their blood supply out, they can't get blood out, what happens? Well, they become engorged. And when you eat, right, there's a more blood supply goes into the gastrointestinal tract. And you can imagine that more blood going into the gastrointestinal tract that can't get out, well, that's going to hurt. So that's why she had pain after she's eating. And then similarly, the intestines become sort of leaky if they can't get blood out. So fluid starts to build up in the abdomen. So you see here, this is called ascites. No ascites initially, then she had progressive ascites, so fluid building up around within the peritoneal space, within the abdomen. And she was miserable. That's why she couldn't eat. You see, she had impaired venous outflow, so blood couldn't get out of the veins, draining her gastrointestinal tract. So what do? Well, you can't go back and really do an operation here. It's too much fibrosis. So, well, shoot, we're really stuck now. But all those techniques apply, right? The idea is that if you can get a wire across this vein here, and then maybe you can use a balloon or a stent to open up that vein. It's a plumbing issue. But then how the heck do you get? Again, this is a privileged space, right? You have to get a vein. You have to wire into this little vein here and put a stent across it. But how the heck can you get there? There's no direct channel because this venous system, you can't. So this is the femoral vein down here. That's normally maybe you'd like to get into the femoral vein, but it doesn't actually communicate with this system. This is a separate venous system that only goes to the liver. Well, then maybe you have to get into the liver to get there. You can see here. And this is, again, a picture of that. So this is the portal vein. This is that scarred down bottom of the portal vein into the superior mesenteric vein. Not allowing blood flow through. So, well, how the heck? So we need to have to get into this. So what we could do, maybe you can think about, is maybe what if we put a needle from the skin right into the liver, and then got into one of the portal vein through the liver, and then delivered tools through that. So yeah, that's what we can do. So we did that. So the idea is we first start with ultrasound, and you find a portal vein. So this red thing right here is a portal vein, and you put a needle in from the skin right here. This is the next picture using the ultrasound machine to visualize a needle going right down through the skin, all the way through the liver, right just into that portal vein right there. That's enough. That's enough of a distant access to just get a wedge into the vein, and then through that you can start getting wires in through that needle. You bring the wires all the way down here through the. And again, this is a live X-ray. So now we started with ultrasound. Now we're into live X-ray, and this right here, where the X-ray dye, you can see here. These are the branches of the portal vein, right here in the liver. Right here is that constricted portal vein by that fibrosis, and again here, it's constricted by the fibrosis of the radiation and the scarring, and that would basically correspond to this area right here. The splenic vein, which should live right here, has long been occluded. That happens very frequently with pancreatic cancer. But again, that's a slow process, and the blood reroutes. But in this case, there's nothing left to reroute. This is too much fibrosis in this area. We do see here is some blood is trying to reroute itself, but not doing a very good job. So after we are able to get a wire across the area of narrowing, we'll then use a balloon. So this picture down here, you can see a balloon has been inflated. That's this dark thing, but you see right there, that's a narrowing. That's a really tight fibrosis or scarring that has scarred that vein down. And then after you balloon it, well, the problem is the scarring will just come right back down, so you need to put a metal cage in to prop it open. So that's what we do. So again, the wire across, deliver that constrained metal stent across, and then remove and let that stent pop open. And then we inject contrast after popping it open again, and you see now blood's nicely flowing briskly across the portal vein, where it's previously occluded, right into, or nearly occluded, into the liver. And what we don't see, initially, right, these are called collateral veins, trying to go towards some other pathway to get out of the body, maybe the umbilicus or the, but now we don't see that. It's briskly flowing inline into the liver as it should. And then the next problem is we've just created a huge hole in the liver, not huge, but a small hole, a couple, several millimeters in diameter, maybe 5 millimeters, 3 to 4 millimeter diameter. But that definitely could bleed through that, because now this liver has a tremendous amount of blood flow. So to close it up, put a little metal coil in along that tract, a little plug of gelatin, and then remove all the tools, and then that's it. Stents open, and then her outcome, right? Again, this is an outpatient. She went home the same afternoon that procedure was done. Her symptoms resolved for at least 6 months, which is great, right? It was opened. She returned to normal diet, no further pain with eating. She regained weight. The ascites resolved, again, because there's good normal blood flow now through that mesenteric portal system into the liver. And again, right, we're talking about this is palliation, right? This is overall survival is still 20 to 25% after pancreatic cancer after a Whipple procedure. But she has a chance now of having that, whereas she would have passed much sooner. Now, in terms of these stents, right, the technical success, they're not done often, but when they are done, they're successful. We probably have 90% of technical and clinical success. And the primary patency at 14 months out is around 80%. So again, they're big stents that tend to keep things open. Good. Any questions on that? Nice. So in conclusion, interventional radiology, it's a procedural specialty defined by a host of techniques to try to address disease anywhere in the body, head to toe. Tremendous amount of collaboration and innovation to try to figure out new ways to apply these techniques to novel disease. And as you can see here, most of the disease is treated quickly with less pain and less recovery. And so here at the hospital, it's myself, Steffen Haider, Herlin Alankar, and Ari Salas are the 3 interventional radiologists. We're always here. It's 24/7 service, so we're always happy to help in any way.
Thank you for joining us today. Our next What's Up Doc presentation is on Friday, October 13th. October is Breast Cancer Awareness Month, and our guest speaker is Dr. Lauren, and her topic is on breast reconstruction surgery. And on behalf of the entire staff, Concord Hospital Trust, Enjoy your weekend and stay healthy, and feel free to ask any questions as well.
Yeah, great. Yeah,
I'm really glad you're here. I don't ever want to need you,
right.
but I'm glad we're fortunate to have you. Is there any body part that you're, I didn't hear you mention the brain, but is there any body part that you're not willing to consider some of your treatment?
Yeah, not really. You know, here at this hospital, we don't go inside the brain itself, but we go around the lining of the brain pretty frequently to treat bleeding. Yeah, for something called subdural hematomas, we treat those. Would be bleeding around the brain. We treat that with these embolization techniques. Not really. Certainly some diseases shouldn't be treated with this embolization. A lot of it is disease and case specific, but as a rule, it's not a specific organ that we'd say no, never to do. We just, wouldn't embolize the heart. And the cardiologists do the heart, but the techniques can be used really anywhere in the body if you can figure out a safe way to do it. Yeah.
Are most of these procedures done on the local or general?
Most are kind of in between. So most are like moderate sedation. So that's a combination of Fentanyl and Versed to create kind of a twilight. So there's no breathing tube for most of these procedures. You just kind of, some folks will remember it, some folks won't, but some folks will kind of be drowsy. But some things like the ablation, sometimes we'll do those with anesthesia because they'd be more painful. But most of this, the vascular work typically is just done with sedation. Or local, for things like superficial biopsies that are close to the skin, we'll just do local only.